Hi, everybody. We'll get started in just a few minutes. There were a few of you that are kind of coming in. So we'll get started right around 7:02 to allow everyone time to come in. Hello, everyone. So glad to see you all. Hope everyone's doing well tonight. Well, it looks like everyone's in, so we'll actually go ahead and get started right now. So welcome, good evening, everyone, and welcome to Talk Saves Lives, an introduction to suicide prevention, brought to you by NAMI Cook County North Suburban and Luma Bonilla-Webster from American Foundation for Suicide Prevention Illinois chapter. AFSP's mission is to save lives and bring hope to those affected by suicide. They fund research to improve interventions, train clinicians in suicide prevention, and advocate for policy that will save lives. They work to find better ways to reach those who suffer and encourage schools, workplaces, and communities to make mental health a priority. The Illinois chapter of American Foundation for Suicide Prevention focuses on eliminating the loss of life from suicide through education, research, outreach, and advocacy. NAMI CCNS, at NAMI CCNS, I am Heather Kendall, the Youth and Young Adult Programs Manager at NAMI Cook County North Suburban. NAMI stands for the National Alliance on Mental Illness, is the largest grassroots mental health organization, providing public awareness, no-cost support, and education programs online and in person so that people and families affected by mental health conditions can build better lives. We offer classes, support groups, presentations, and advocate for mental health. Our programs are free and open to those in our community service areas. We are so pleased to have you all here tonight. This year, each month, mental health professionals will dig deep into a variety of topics to further educate us on community members' topics of interest. During this workshop, we will be introduced to Talk Saves Lives, AFSP's flagship suicide prevention education program that covers the scope of this leading cause of death, what the research has found to be the warning signs and risk factors of suicide, and the strategies that prevent it. We will talk about the scope of the problem, research, prevention, and what we can do. Our Q&A will be held at the end of the presentation. However, if you would like to type questions in the Q&A box or in the general chat during our conversation, please do. Our speaker tonight, Luma Bonilla-Webster, is the programs manager for the American Foundation for Suicide Prevention's Illinois chapter. She has expertise in program management through grassroots, community building, movement organizing, and recruitment and group facilitation. Having dealt with her own lived experience as well as supporting friends and family through mental health challenges, Luma is dedicated to the cause of mental health awareness and suicide prevention. She is trained in mental health first aid and living works assist. Luma is currently pursuing a degree in sociology. We are so thrilled to have her tonight to further educate us on this ever important topic. I am honored to welcome our guest speaker, Luma.
Hi, thank you, Heather, for trying so hard.
I'm so sorry.
Right, it's all good. I appreciate it. So thank you everybody for joining us. Again, my name is Luma. I am the programs manager for AFSP, and today I have our flagship program, Talk Saves Lives, as Heather mentioned. So I'm just gonna go right ahead and get us started. We are gonna wait to the end to take questions just because there's a lot of content to cover tonight. So this is just the obligatory. This is for educational, informational purposes only. Heather kind of went through all about AFSP, so I won't dig too deep into this. I'll just say that, like Talk Saves Lives and our other programs, they are funded through our community walks. Our walks are what make our programs available for free for the community. I'll have some more information about the walks towards the end of the presentation. And I'll also add that our research informs all of our programs. So if you're interested in citations or information about what's part of the program, I would be really happy to share that with you. Okay, so just like physical health, we all have mental health. Mental health includes our emotional, our psychological, and our social well-being. And our brain really plays a big role in our mental health. Research shows that most people who die by suicide have a mental health condition at the time of their death. It may or may not have been recognized by the person who died. It may or may not have even been adequately treated or diagnosed. That said, research has made it really clear that also mental health conditions are not part of the whole story, but it's important that we make sure that we're taking care of our mental health. 1 in 4 people will experience a mental health condition, but most do not go on to die by suicide. So Talk Saves Lives provides guidance to community members on how to recognize the warning signs, how to have a conversation, how to connect people to help. But we also have a really robust public health strategy for suicide prevention. That includes implementing education, just like I'm doing today, and health promotion in all different settings, or as many settings as possible, whether that's from healthcare to schools to workplaces. We also want to try our best at changing social and cultural norms to decrease stigma and encourage help seeking. We do that through our PSAs and educational outreach and advocacy. We also work on identifying selective and targeted prevention strategies that are backed by research. And we do increasing access and awareness of effective treatments for mental health conditions like depression or anxiety. We also do a lot of advocacy for health, economic, educational, and social policies that help reduce inequalities between groups in society to advance mental health care, and particularly for underserved communities. So we work across all these various strategies, again, with that goal of creating a culture that can help us address and prevent suicide. So hopefully tonight you'll learn how to describe the impact of suicide, how to identify contributors and risk factors to suicide, understand how suicide may impact communities differently, describe and recognize different warning signs, learn how to have a conversation about suicide with someone that you might be concerned about, and then how to seek help, not just for others, but for ourselves as well. And before we even get started on all of that, something that's really important for us in addressing that culture and stigma for mental health and suicide prevention is addressing about how we talk about suicide. Because we don't want to contribute to that stigma. So oftentimes you'll hear people say, someone committed suicide, but I want us to stop and think for a second about the word committed. And some of the things that come to mind right away for some people when I talk to them about this is like committed a crime or committed to an insane asylum, which we used to do in the past. There's also really negative association with suicide and religion, right? It used to be considered a sin. You couldn't be buried with your family. You may not get church services. So there's a lot of historical context using the words committed, and then just general context within the word suicide in general. So to try to help us address that, we want to make it easier for us to talk about suicide and mental health, right? So instead, we prefer to use the terms like died by suicide, ended their lives. This is also really helpful for us to remember that we don't talk about suicide in the same ways when we're talking about other conditions, right? So we don't say like someone committed cancer. And so similarly, we want to make sure that we are careful with our language when we're talking about suicide prevention. Some of the terms that you might hear me use today are suicide loss survivor, survivor of suicide loss, suicide bereaved, bereaved by suicide, and this just means people who have experienced a suicide loss. Lived experience might refer to someone who has experience with an attempt or a mental health condition, or suicide loss in general. And then suicide attempt survivor, I think that one's pretty obvious. So what we want to encourage and let people know is when we talk about suicide safely and accurately, we can help reduce that judgment and stigma around suicide and encourage people to seek help. So suicide is a leading cause of death in the United States. We lose nearly 50,000 people to suicide each year. Well over 1 million people attempt suicide. Millions more have thoughts of suicide. For those folks or those numbers that we have about suicide attempts, that's just for numbers that are reported. So that's for folks who visited a hospital or care center after an attempt, or who reported their attempt to a clinician or their therapist. This does not include attempts that might have been done at home and survived, because again, there's a lot of shame and stigma around this. So there could be more, that number could be bigger. We do know, though, that the impact of suicide on families, on friends, on communities is really far reaching, even long after a person has taken their life. And we also know that most people have been affected by suicide in some way. So let's look at the differences in suicide rates. So all populations are affected by suicide, but there are lots of different factors that contribute to differences in suicide rates for different populations. These can include things like access to healthcare and support, experiences of marginalization, access to lethal means like firearms. So while at a population level, some communities experience more negative conditions or factors that increase the risk of suicide, identifying as part of any of these communities doesn't inherently mean that an individual is at risk of dying by suicide. It's just going to give you an idea. So on the slide, we have different examples of groups. So for example, males have higher rates of suicide than females. Though I'll note that females tend to attempt suicide at higher rates than males. Males just use more lethal means. Middle-aged adults and older adults have higher rates of suicide than younger people. Veterans have higher rates of suicide than non-veterans or civilians. And suicide rates are 3 times higher in homes where there is a firearm than those without. And then some more information. So you still have the lowest suicide rates compared to other age groups, but unfortunately, the suicide rate in these age groups has been on the rise. Suicide rates are lower among people of color, but these rates have also been increasing at very fast rates. Suicide rates among Black, Asian American, and Pacific Islander youth have also been found to be increasing. And Indigenous youth and young adults die by suicide at higher rates than any of the other racial or ethnic groups. I'll also add that unfortunately, research is still lacking around suicide deaths for some groups. We suspect that some groups have higher rates of suicide, including groups with disabilities or LGBTQ communities. And although we don't have suicide death data, there is data demonstrating higher rates of suicide and attempts within these communities. So this is information on rates among industries and occupations. So in the US, most people who die by suicide are people of working age. The CDC classifies occupations into major groupings by industry and by occupational groups. And you can see some of the higher rates listed here. So actually, the mining, quarrying, oil, and gas industries have the highest rates of suicide, but construction is just under that. I'll add here that we just launched a Talk Saves Lives program for construction industries that goes into more detail on the topic of suicide for construction. So when someone dies by suicide, people may see a life event or life stressors like losing a job or going through a breakup or struggling in school, and then we'll assume that that event is what caused the suicide. But we know through research that suicide is complex. There is no single cause for suicide. Behind the scenes, there are multiple risk factors that can converge to contribute to the risk of suicide, and these factors may not be noticeable. They may or may not be known, right? We kind of group them in 3 different ways, which is biological factors, psychological factors, and then social and environmental factors. So it's all these interacting risk factors that are kind of playing a little bit of tug of war with each other, on top of current life events or stressors, with access to lethal means that can potentially lead someone to suicide. And here we can kind of see what those interacting risk factors can look like. So we have contributors to suicide, or risk factors, which increase a person's risk of suicide, and then protective factors, which would decrease a risk for suicide. So like a protective factor could be access to coping skills, access to care, access to social environments or connectivity. While a risk factor may be something biological, like pain, or psychological, like in diagnosis of depression. Um, our social and cultural environment too. So whether or not we're in poverty or we're struggling. So all of these things on top of life events and access to lethal means can potentially lead someone to suicide. And I can kind of go through these a little bit more. So contributors or risk factors could be things like previous suicidal behavior, mental health conditions. Again, we know that most people who have died by suicide had at least one mental health condition at the time of their death, but depression and bipolar disorder happen to be the diagnosis most associated with suicide. Past attempts might also indicate risk for future suicidal behavior, but past attempts alone do not predestine someone to suicide. Notably, I'll add here that the vast majority, around 90% of people who have survived a past attempt, will not go on to die by suicide. A family history of suicide or mental health conditions, as well as exposure to suicide, can contribute to risk. Physical health conditions and chronic pain can also increase risk, especially following the disclosure of a diagnosis. And then traumatic brain injury can lead to depression, difficulty problem solving, impulsivity, aggression, or even disability. All of these things which can increase a person's risk. And then lastly, I also want to highlight some social factors that can include the presence of severe ongoing interpersonal conflict, rejection, victimization, race or gender-related discrimination, prejudice, systemic racism, or any sort of historical trauma. All of these can increase our vulnerability to suicide. And then we have a little more on those protective factors. So these reduce a person's risk for suicide. I mentioned earlier they can include coping skills, but they can also include sources of strength and resilience. A person's resilience to overcome difficult and challenging barriers in their lives, their ability to connect with other people who can provide them emotional support and ground them, support from people who love them. These can mitigate the impact of the risk factors that I was talking about earlier. A person's willingness to participate in mental health care, as well as the availability and access to care, plays a really important role, because participating in mental health care can be life-saving. It's also important to note that protective factors are powerful and they are important, but even individuals with many protective factors can still experience a suicidal crisis, because remember I said earlier, suicide is complex. So if anyone can experience suicide risk, why do certain groups and populations have higher suicide rates? We're gonna explore some potential factors that can increase risk for certain communities. But again, just a reminder that identifying as part of any or one or more of these communities does not mean that you're inherently at risk for suicide. Most people have overlapping identities and varying experiences that can contribute to their risk. So starting off with suicide in older adults. So for individuals 65 and older, certain life circumstances may increase their risk. They tend to live alone, so they may have increased feelings of isolation. They're also more likely to have experienced the loss of a partner or close friends or family members. For them, losing a pet can also be really significant, especially if they already live alone. Changes to their health can lead to loss of independence. Major role changes like retirement can also put them at risk, especially for those people who their career played a really big role in their personal identity. It's also really important to understand that depression is not a natural part of growing older. It is a treatable health condition, and if left untreated, can be life-threatening. We'll also note that when older adults attempt suicide, those attempts tend to result in death more often, again, because they might live alone. They also might have greater access to lethal means by medications. there's also the increased likelihood of a serious health condition that would make them less likely to survive an attempt. So it's really important that we're supporting older adults through their life changes, having a conversation with them, checking in on them, discovering new hobbies with them, encouraging community connectedness. These things can be important protective factors for older adults. Then we have LGBTQ community members. So I mentioned earlier, unfortunately, research and data around suicide for LGBTQ members is still lacking. But what we do know is that research shows that they experience more suicidal ideation and suicide attempts than their heterosexual peers, particularly for lesbian, gay, or bisexual community members. While suicide data among trans individuals is really limited, one study found transgender individuals were almost 9 times as likely to attempt suicide than the general population. There are some studies that have reported a generally strong association between mental health conditions and suicide attempts in LGBT adolescents and adults. And then there's research that shows that part of the reason for elevated rates of suicide in the LGBTQ community is the social stigma, prejudice, discrimination that's associated with identifying as part of a minoritized sexual orientation or gender expression. So for youth who are part of the LGBTQ community, it's important that we provide social support, that we encourage them, that we connect them to resilience and community, that we have increasing acceptance and affirmations for their identities, and also increase access to physical and mental health care for that community. And then additionally, we have our veterans. So for more than a decade, suicide rates have been higher and have risen faster among veterans compared to non-veterans. The suicide rate for veterans is about 1.5 times higher than that of the general population. And while veterans are vulnerable to some of the same risk and protective factors for suicide as others in the general population, they are still more likely to experience homelessness, unaddressed mental health concerns, or general health concerns, and they tend to struggle with personal relationships. Among US adults who died by suicide, firearms are more commonly used among veteran deaths, with nearly 75% of veteran suicides involving firearms. So firearm ownership or firearm storage is really important, because firearm ownership is over twice as prevalent among veterans and non-veterans. About 1 in 3 veteran firearm owners store at least one firearm that's loaded and unlocked. So there's also occupational risk factors for veteran suicide, which can be previous exposure to traumatic events, including events from pre-military service, military sexual trauma, or combat exposure. There's also really, they have a really big difficulty in transition back to civilian life, particularly that first year. It can come with a sense of like lost identity, among other challenges. And although not unique to veterans, loneliness and loss of peer connections are risk factors for suicide that can be really heightened, again, particularly during that first year of transition. Veterans who have attempted suicide were more likely to have a diagnosable mental health condition, including post-traumatic stress, major depressive disorder, substance use disorder, generalized anxiety, and they have really poor sleep quality. Many veterans also have, unfortunately, a higher perceived stigma about accessing mental health care. So some strategies that could be really important for veterans, including addressing those common misperceptions about mental health care, about household firearm risk, including teaching them some safe storage strategies, increasing their access to and their use of mental health services, transition services for them. Those strategies can be really impactful for them. Okay, so hopefully now we understand how different groups are affected by suicide. We're going to talk a little bit more about how someone in crisis might be struggling with suicidal thoughts and behaviors. Again, keeping in mind that suicide is complex. Thoughts of suicide can also be complex. Each person has their own path to feeling suicidal or attempting suicide. We know that research shows that most people who experience suicidal behaviors are ambivalent about taking their life, Part of them wants to live, part of them wants to die. The thought of ending their life is usually a part of their mind's problem-solving process. And it's not necessarily that a person wants to die or that they have some sort of morbid preoccupation with death. It's usually that suicide comes to mind as a possible solution to end their suffering. They might also think that if they weren't around, it would be better for their family, their friends or colleagues. They feel like they might be a burden. They also might feel that their psychological or physical pain won't change, and they might feel overwhelmed with hopelessness. Also, just important to remember what I mentioned earlier, that millions of people have thoughts of suicide each year, but most do not go on to make a suicide attempt. So thoughts of suicide do not necessarily lead to suicidal behaviors, but suicidal thoughts do signal that someone might be in distress and they need to have professional evaluation or assistance. So through research, we've also learned about the perspective of someone who might be in crisis. We know that their thinking becomes constricted, causing something we call like an intense state of tunnel vision, where in that crisis moment, this person is unable to consider any other options and they don't have access to their coping skills. They cannot foresee a time when that unbearable physical or emotional pain may end, and they may become focused on suicide as the only way to end their pain. So thoughts of suicide are often temporary. Research also provides lots of clear evidence that in a moment of crisis, time and distance can be life-saving. So time for that intense crisis moment to pass. Time for someone to intervene with mental health services, and distance between the individual who's experiencing that painful moment, that crisis moment, and their method for ending their life. So next, we're going to talk about some steps that we can do to help save lives and prevent suicide. We'll learn about watching for warning signs. We'll learn about reaching out to have a conversation with some examples. We'll learn about how we can keep the environment safe, and then how we can connect to help and resources. So we have 4 sections. So warning signs. We talked about, I'll just backtrack for a second because we talked about risk and protective factors. Risk and protective factors endure over longer periods of time, or they're unchangeable, whereas warning signs are more immediate, observable signs that someone may be at risk. So for example, like if you have high blood pressure or high cholesterol, these might be ongoing risk factors that could increase a person's chance of having a heart attack. But having chest pain is a warning sign because it may signal that a heart attack is happening now, just to kind of help place this. So suicide warning signs are typically displayed in 3 different ways. We categorize them as talk, behavior, and moods. Sometimes people who experiences thoughts of suicide may talk about it. They may say it jokingly or passingly to see if anybody's paying attention. We want to make sure that no matter what they're saying, that we're taking them seriously. Some things that people might say is they might feel like they're a burden to others, or that they feel like they're in unbearable pain. They might say things like, I wish I could go to sleep and not wake up, or I don't want to be here anymore. That's the type of negative language that we're looking for. And then for behaviors, we're looking for things that you might notice in someone that's acting differently than they normally or usually do. You may see that they're beginning to use substances, or that there's an increased use in substances. You may notice that they're having trouble sleeping. Either they're having trouble falling asleep, or they're staying asleep or sleeping too much. Sleep is one of the bigger signs for a lot of people. Sleep for the general population is really important and helps regulate us. So issues with sleep, or watching for issues with sleep, is really important. Folks may start acting recklessly. They might withdraw from activities, especially for activities they might normally enjoy. And again, we're looking for behaviors that are atypical. So maybe somebody has a habit of like switching hobbies all of the time, or different activities. That's normal for them. But if somebody is switching activities or leaving activities that they normally love and that's not normal for them, that's what we want to watch out for. The other one is that I want to really highlight is giving away possessions. So folks who have made a plan and who believe they may no longer be here might give away items that were really important to them, to family members. And then lastly, mood. So people at risk for suicide may display, sometimes subtly, changes in moods. Again, we're looking for atypical things, right? So depression, anxiety, apathy, rage. For men in particular, they tend to exhibit more like anger or rage or irritability. Also want to highlight on this section, sudden unexplained happiness. So the way this usually presents itself is for folks who may already have a history of attempts or depression or anxiety, and they might suddenly exhibit happiness if they have made a plan. Oftentimes we hear from family members or people who have lost someone to suicide who say, well, we thought that they were doing so much better and that things were working. That's when we really want to make sure that we check in because it's possible that they might have made a suicide plan. So the second step is having a conversation with someone. We don't want to assume that someone else is going to reach out to them, especially if we're noticing warning signs. We might want to check in to make sure that we're the right person to have their conversation with them, especially because we want them to open up to us. We also want to make sure that we're having a conversation in a private space where they feel comfortable and safe speaking. I also want to acknowledge how difficult and uncomfortable and scary it might feel to have this conversation. But also remember that all of us have mental health, and talking about it in a non-judgmental way really makes sure that you're a trusted person. If you're worried about someone and that they might not get help, we want to make sure that we check in. And if we do and suicide turns out to not be a concern, they might feel comforted just knowing that you checked in and that you care about them. So I'm going to give up some examples. So first, we want to avoid minimizing their feelings. The way that they're feeling or how they might approach things might not be the way that we would see or approach things, but we want to validate how they're feeling. We also want to avoid getting into philosophical debates about life being worth living. If a person is nearing a crisis point, they are not thinking clearly. Remember, we talked about tunnel vision. So those conversations tend to not be helpful. We also want to avoid offering advice on how to fix their problem. If a person were having a heart attack, we wouldn't tell them to start exercising or to eat a healthier diet in that moment. The same is true for someone who is having a crisis. Lastly, it's not your role to diagnose or provide mental health services. We want to encourage the person we're speaking to connect to help and assistance. Some examples of how you might lead this conversation. I care about you. I've noticed that you haven't been yourself lately. You seem more frustrated, angry, irritable than you've been in a while. I'm wondering how you're doing. So there's just some examples that we could use. So we also want to listen with empathy and active listening so that we can show them we care, and it allows you to get more information about their level of distress. We want to ask open-ended questions. We want to encourage them to share. We want to stay calm, and we want to listen for warning signs. Some things that you might say to kind of keep the conversation going, how has that made you feel? That sounds really hard. Can you tell me more? Are you having a hard time with that? I care about you and I want you to be safe. So asking directly about suicide. Some people really worry that asking about suicide might put the thought in their head or might spur them to action. The reality is that research shows that that is not true. If someone is considering suicide and we ask them directly, they tend to feel relieved that somebody cared, that people are watching, that they might not actually be alone. However, I will say that it might be difficult for us to notice these signs or to even ask them directly. So A quick tip, if you think you might have to ask this question, it might be helpful for you to practice beforehand so that when you do ask and the answer is yes, that you remain calm and connected with them instead of panicking. If they're not thinking about suicide, we want to continue to listen and provide support for them, revalidate what they experienced. I'm sorry you hurt so much. I care about you and want you to be safe. I want you to find the help that you need. Here we might want to schedule a time to like reconnect with them and check in and make sure that they are following care or that they've taken steps to help themselves. It also helps them keep them connected. You might even bring a larger community support group or friends and family to kind of help them manage this. If they are thinking about suicide, we want to stay calm, like I mentioned earlier. Just because someone is having thoughts does not mean that they're in immediate danger, right? So we want to listen calmly. We want to listen to what they have to say, and we want to ask follow-up questions so that we can learn more. So you might ask, do you have a plan? Do you have a method? Is that method available? Can you give that to me until we get you through this difficult time? Reiterate, I want you to be here and I want to help you. Again, we want to avoid the philosophical life debates here. We want to avoid saying things like you have so much to live for. Think about your family, spouse, parents, etc. Again, they might be nearing a crisis point and thinking may be constricted. So we want to reassure them that help is available and that these feelings signal that it's a time to reach out for professional mental health care. If you think that they might make an attempt soon, we want to try to stay with them and help them remove those lethal means, make sure that we get them access to mental health services. Ideally, some sort of, if they're willing to access care, some sort of behavioral center, or hopefully they'll have healthcare services or therapy services available. If not, offer to make that call with them there. Also 988 is also available, which I'll share in a little bit on the other slides. So some next steps to kind of close the conversation, again, reiterate that you're so glad for the chance to connect with them, remind them that we all have challenges in life and that you'll continue to be there for them. But don't just leave it at that. As I mentioned earlier, make sure you're doing follow-up care, you're checking in with them. You might bring in other community members, friends or family, etc., to kind of build a network of support for them. You might say, thank you for sharing with me. Do you want me to help you call your therapist? Or, you've been on my mind since we had that conversation. How are we doing today? We want to make sure that we're checking in. So in the next couple slides, we're going to talk about keeping the environment safe. And also want to add here that the most important thing you can put between a person thinking about suicide and their way of ending their life is time. Research shows that temporarily reducing a person's access to lethal means can give someone in a crisis time for that intense state of tunnel vision to diminish, time for someone to intervene and provide mental health support or resources. We also know through research that crisis moments don't last very long. They could last anywhere between a couple minutes to a couple hours at most, maybe a couple of days, but they don't last forever. And we want to make sure that we can help them through that crisis period. So I keep mentioning lethal means, but lethal means refers to a method that can be fatal if one uses it to attempt suicide. So limiting access to lethal means securing or reducing access to those methods, especially in their home environment. It is a proven strategy that helps to prevent suicide. So another tidbit for most people who are or who may be in suicidal crisis, if they are unable to access their chosen method, even temporarily, they are unlikely to seek an alternate means to end their life. So again, a clear way to help prevent suicide is to limit access to lethal means. So some of the examples of what we might do is securing medications, securing toxic substances, securely storing firearms. I wouldn't recommend removing firearms from their home because they're usually registered to their person, but we can disassemble it and take the parts with us. We can also take the ammunition, or make sure that the firearms are stored separately from the ammunition, preferably different locks, preferably different combinations. You can also ask the person what they need to feel safer and encourage them to refrain from substance uses, and encourage them to keep their environment safe. If they're already seeing a mental health professional and they've made a safety plan, you can also ask what's on there if they're willing to share with you, and you can go over it together. So a little bit more about suicide and firearms. So nearly half of all US households have at least one firearm. If someone is at risk for suicide, having a gun in the home can be really fatal. Around half of all suicides in the US involve firearms. In some states, firearms are used in as many as about 70% of suicides. In Illinois, I believe that number is about 30%. So also most firearm deaths in the US are actually suicides. So this information just tells us how important it is that firearms are stored safely. We want to lock, limit, and temporarily remove. So lock firearms when they're not in use. They should be locked and unloaded. Ammunition should be locked in a separate space. We want to consider taking steps to limit access to firearms, like changing combinations, changing locks, or giving keys to a trusted person, and then temporarily removing firearms in the home if that's possible. You might want to check your county or state's transfer laws. Again, worst case, I wouldn't recommend taking the firearm, but if you disassemble it, you can take the parts with you. Okay, crisis resources. We talk about 988. I think hopefully most of us know about 988. You can call on behalf of someone. You can call, though usually the recommendation is to make sure that the person you're calling for is there so that they can help them. But if you don't know what to do, you forgot everything I said, you can call 988 and ask them for assistance, asking you to give you tips on how to talk to someone, encourage them to call 988. You can call or text them. We have the line in Spanish and the line for veterans. Fortunately, no longer have the LGBTQ 988 line. However, that is still being processed through the Trevor Project. It's not 988 anymore, but you can call the Trevor Project number if somebody who is part of the LGBTQ community is in crisis. Calling 988 can be a really great step if there's no immediate danger, but if someone's in a medical emergency or life-threatening situation, like there's an attempt in progress, we want to make sure we call 911. Also want to caveat that while 911 can be life-saving, it may or may not be the best choice for law enforcement to respond if you're a person of color, or if you're part of the Black community. We want to acknowledge that there might be an increased risk for those communities when a mental health crisis is involved, but there are things that we can do. If we need to call 911, we want to let them know that this is a mental health crisis. We want to ask for crisis intervention trained specialists, which usually accompany law enforcement to mental health calls, and they're the ones that lead the response to the call. Not all communities have these mobile response teams, so we want to check with your county first to make sure if there is one. And then an alternative might be making sure that you know where your local emergency rooms are and where urgent care services are. But if it's a medical emergency, we will want to call 911. Here's some resources for connecting to professional care. Some of these you can find under Find Treatment at samhsa.gov. We also support inclusivetherapist.com. Most people who are seeking help should request a thorough evaluation to figure out if they have a mental health condition that's affecting their life. There's lots of different types of treatments available, including psychotherapy and medications. We know through research that it's the combination of psychotherapy and medications that tend to be the most helpful for most people. These treatments can also help develop a safety plan, something I mentioned earlier, that helps them when they are in crisis. Again, the most important thing we can do is help connect someone to mental health as best we can. I'll also, again, just another acknowledgement that I know that there are barriers to accessing care, including a lack of mental health professionals especially therapists of color and LGBTQ affirming therapists, or just generally culturally responsive therapists. There might be other barriers to accessing mental health care, like cost or the ability to take time off to even go to therapy. But there's lots of more options available, like sliding scale, varying hours. Just takes a little bit more research to try to find that type of care. And this is a little bit about postvention support for suicide loss survivors. We have lots of resources on our website, but the Doogie Center also has resources for grieving children and families, TAPS for our veterans, and then Alliance of Hope for suicide loss survivors also has lots of resources. We talked about a lot of things. We talked about protective factors earlier in the presentation. So in addition to all of those things, having really good self-care strategies, like good sleep habits, especially sleep. I can't overemphasize making sure that we're taking care of our sleep. Exercise, nutrition, stress management, coping strategies, all of these play a really important role in helping to take care of our mental health, but also to promote resilience. So take some time to take stock of that, build your community and support so that you're not doing this alone. But it's important that we're taking care of our own mental health the same way that we take care of our mental health. Because together we can create a culture that prioritizes mental health and suicide prevention. So I'm going to skip this section real quick just to tell you a little bit about some upcoming stuff that we have going on. We do have lots of virtual programming in September. We also have stuff coming up in November, which is our International Survivors of Suicide Loss Day. If you want information on any of these programs, feel free to email us at illinois@afsp.org. And then you might know this already, but we also have our community walks. So I encourage you to take a picture or a screenshot. And hopefully you might be able to register for a walk near you. The walks help to fund our programs so that they are always free and we don't have to charge anyone for showing up and being in community with you all. So I think I will also share this copy of the slides with Heather so y'all can get access to them later on. And the last thing I will ask for you, if you could just take a moment to provide some feedback for our program. This version of Talk Saves Lives was launched after a total revamp from the previous Talk Saves Lives, which was about 15 years old, back in August. And through feedback from the surveys, we've already made some additional changes. So your feedback is really important for this program. And I will end it there for questions.
Thank you, Luma, for providing this information. It was extremely helpful. I know our guests tonight have some questions, so we can go ahead and start the conversation. One question did ask if you would be able to share the slides. And you've already answered that for us. Some of the other questions were questions for us, but I was wondering, I think I teach youth mental health first aid, and I know you said that you're also a youth mental health first aider. It sounded like some of the information was very helpful and kind of based on our mental health first aider information that we typically give out to people. Is there a situation where, where someone has asked in one of your trainings about like an example when we teach people, because we usually work through examples? Is there anyone that's ever stood out in your mind that you would want to share comfortably?
Like someone who might be having a crisis?
Yeah, or thinking about suicide as.
Yeah, so lots of times when we have conversations in community, actually most of the time it's really difficult for me to get folks to open up. I think that could be a lot of different reasons. I think we still tend to think suicide as a really difficult topic, even though we're trying to promote more cultural awareness and openness in talking about mental health. But I think, like I mentioned in the presentation, some of the things that we can do is just listening to folks in their struggles, oftentimes what most people want is just to be heard, but they might feel ashamed or they might feel like they shouldn't, especially for those cultures where we don't talk about our mental health because, you know, we're supposed to be strong, or you know, we don't talk about those things. So encouraging people to, especially if we notice signs of struggling, and we want to, this is an opportunity when we're talking to someone, we actually want to do as little of the talking as possible and allow them to do as much of the talking as possible, and trying to get as much information as we can. And then also, I think I'll add here too, I kind of mentioned this a little bit, but most of the times when folks feel isolated, part of that is just not being heard, but also part of it is that just generally we tend to be more like individual culture, where, you know, we don't talk to our neighbors, we don't do large community events sometimes, it's depending on culturally, right? So encouraging people to find community connectedness to try to avoid having those feelings of loneliness is really important. But also, again, just making sure that we're accessing mental health care. We always want to encourage people because we do want to make sure if there is a mental health condition that it gets properly diagnosed, because in that case, no matter what you do, if you provide all the protective factors, someone might still be struggling because it might actually just be some sort of, you know, brain imbalance, or they need a diagnosis of depression or other things. So it's checking in and making sure that they're connecting and following up with that sort of care. But yeah, so kind of like general practices is just making sure that we're letting people talk more than what we're asking questions, and just giving them the time because people just want to be heard.
Definitely. And Nancy said, thank you so much. Take good care and have a nice rest of your week. Yeah.
Thank you. I will add that Talk Saves Lives, this program recently earned recognition from the Suicide Prevention Resource Center, and it's now part of their best practices registry. So hopefully you'll see a little bit more about the program, but if folks want to learn more about it or bring it to their community, again, feel free to let us know. I'll also share that folks can be trained to provide this program. We do the trainings for free. So if you want to share this within your community, again, let me know, and I'll be happy to share more information about what that might look like.
So we did have another question come in. They're asking, how can you help someone who isn't willing to access mental health resources?
Yeah, I get this question a lot. It is really difficult because we want consent to provide treatment. There are certain times where, because of their diagnosis, it prevents them from feeling like they even need care. So it's a bit of a complex question. I would say some things that have worked is to try to address the underlying why. So as an example, if a person of color is not wanting to access healthcare because they've been previously mistreated or had racist experiences, or just have a general distrust of the healthcare industry overall, that might be their reason for not wanting to get access to healthcare at all. And so we need to address that first. And there are ways that we can do that, right? Helping them find inclusive therapies or culturally representative therapies, because there are some out there, not as many as we would like. I think there's a statistic out there where only about 4% of all of the available therapists are Black therapists. So like there's just a tiny number of available therapists for the amount of population, community members that there are, right? So that might be a little bit of a barrier, but there is still availability of care. So I think trying to address the underlying why that's beyond just pushing them to get mental health care. And I know I said that we want to make sure that we connect them to care, but if they're reticent to it, we want to find out their reasoning. Why is that you don't want to get care? And if we can get to the core of that, maybe they would be more willing to receive care overall. That's another great question.
Yeah, thank you. I just wanted to add that some places have like free support groups, like NAMI does, for
Mhm.
people who live with a mental health condition that's run by peer facilitators who, again, have their own lived experience. I
Mhm.
think that there are some other nonprofits like No Shame on You that also provide resources like that. So sometimes it's like Luma said, getting the conversation started and really listening to them and getting to the why. Sometimes someone just needs to have some validation, and then you can
Mhm.
from there just a little bit at a time. And it's not an easy road, especially for someone, even with us with lived experience, sometimes don't want to hear what we need to hear too.
Yeah.
Yeah.
That's true. I'll also add sometimes like people have bad experiences with like medication. Like I know I did. And that might like push us off from that a little bit. I didn't mention this, but one of the things, this is part of like another program, but something that we talk about is, making sure that we're in communication with our healthcare team to let them know, hey, maybe this isn't working for me. Sometimes we don't feel like we can advocate for ourselves. And so if we get to that why, and the why is like, I don't know how to talk to my therapist about this issue or my doctor about this issue, maybe offering to help them with that process can kind of help with that willingness too, so they're not doing them alone and they feel like they can advocate for themselves a little bit better. But also just in general, being communicative about what is working for us and what is not working for us is really important.
So we had another question. Where can I get the valuable information that Luma talked about tonight? Uh, she is going to share the slides with us, but is there somewhere on your website where you have the resources readily available?
So there's a lot on our website. I encourage you to kind of go through and read through everything that's on there. We also publicize our research on the website too. So if you wanted to learn more about publicized research, that's afsp.org/research. You can read through all the different papers. Some of them are a little long. Most of them are actually not. And like the cover pages provide a really good summary of the background and information. So that's one way to try to learn more if you want to about the new research, and lots of other things. So that would probably be the best suggestion. I'll also say that I was going to add something else, but I don't think that's actually available yet. So, but I'll definitely share the slides with everyone so that you can refer back to the presentation for the information.
Thank you. That's very kind. I think that's all the questions for tonight. So we're gonna go ahead and wrap up. If you enjoyed tonight's program, you can find more information about our upcoming programs and events at www.namiccns.org. Our next program will be held on October 22nd from 7 to 8:30 p.m., where NAMI CCNS and Open Studio Project will educate us about integrating art and mental health. A new NAMI CCNS program called Peer to Peer, a free 8-week class for adults living with a mental health condition, will begin on October 8th and be held every Monday from 6 to 8:30 p.m. until November 24th. Please see our website for registration. The NAMI CCNS Walk is on September 27th at Gallery Park in Glenview. Please join us. We would love to see you there. Once you log off, you will see a brief survey that will both allow us to better understand your comfort level with today's topic, as well as provide us with information we need to raise money to continue providing free mental health services in Cook County North Suburban area. We appreciate your presence tonight, and we look forward to seeing you again at another NAMI CCNS website and community webinar. Sorry. And I'd just like to give another thank you to Luma tonight. You did a wonderful job with a lot of information and a lot of valuable resources. And Michelle also said, thank you so much. Excellent presentation.
You're
So
very welcome.
good night, everyone. And thank you, Luma, again. Have a good rest of your week. All right. Thank you. Bye.